Hey everyone, and welcome. Today, we are jumping right into a super important topic, one that's absolutely critical for any clinical pharmacist: infective endocarditis. We're going to break down everything: how to spot it, how to treat it, and how to prevent it, all from the pharmacist's point of view.
So here's what we've got on tap. We'll kick things off with the basics of what IE even is. Then we'll get into why it can be so tricky to diagnose. The big part of our discussion, though, will be on antibiotic regimens. That's really where we get to shine. And we'll wrap it all up with prevention and some high-yield clinical pearls you can start using like tomorrow.
All right, let's lay the groundwork. First things first, what exactly are we up against when we're talking about infective endocarditis?
So, at its core, IE is an infection of the endocardium. That's the inner lining of the heart, and it almost always goes for the heart valves. Now, this is not just any old infection. This is the real deal. It's life-threatening. Basically, bacteria set up camp and form these things called vegetations on the valves, which can break off and cause all sorts of chaos, like heart failure or strokes. This is why our management has to be spot on.
Okay, so what's the game plan? Well, the first two goals are pretty obvious. You got to kill the bug and make sure the patient is stable. But look at these last 2 points. This is where pharmacy becomes absolutely essential. Minimizing toxicity from weeks of high-dose IV antibiotics, that's us. Counseling patients on how to prevent this from ever happening again, that is 100% our domain. But here's the thing. Before you can even think about treatment, you have to be sure about the diagnosis. And diagnosing IE, well, it's not always cut and dry. That's why we rely on a very specific set of criteria. And that gold standard is what's known as the modified Duke criteria. The best way to think about this is like a clinical scoring system. It helps us add up all the evidence to figure out just how likely it is that a patient truly has infective endocarditis. The criteria are split into two groups: major and minor. The major criteria are the big guns, the heavy hitters. We're talking positive blood cultures with a classic IE bug, or actually seeing evidence of the infection on an echocardiogram, like a vegetation. The minor criteria are all the supporting details, things like a predisposing heart condition, a high fever, or those classic physical exam findings like Osler nodes. And this is how it all comes together. You can see how you need a pretty solid combination of evidence to land on the diagnosis of definite IE. This final classification is the trigger, you know? It's what gives the whole team the confidence to say, okay, we're committing this patient to a long, tough course of IV antibiotics. Which brings us right to the heart of it all for us as pharmacists: figuring out these pretty complex antibiotic regimens. This is where our knowledge of bugs, drugs, dosing, and patient counseling really makes a huge difference. Now, before you can pick the right drug, you've got to know the enemy. And in the world of IE, the big three are all gram-positives: staph, strep, and enterococci. Just look at that. Together, they're causing about 70% of all cases. So pretty much everything we do, empirically or targeted, is going to revolve around them. So let's start with the most common one: staph. For good old MSSA, cloxacillin or cefazolin for 6 weeks is your standard. Now, here's a massive clinical update, so listen up. We do not add gentamicin for Synergy anymore in native valve IE. The evidence just isn't there. It adds toxicity with no clear benefit. For MRSA, of course, it's vancomycin, and our job is to dose that thing perfectly to hit that therapeutic sweet spot. Kill the bug, but spare the kidneys. And this is why our role is so hands-on and critical. We're not just dispensing drugs, we're actively managing them. For Vanco, we're counseling on that infusion reaction. If we end up using daptomycin, we're checking for muscle damage and telling patients, hey, if you get any muscle pain, you need to tell us right away. And with rifampin, we're warning them about the orange tears and sweat. But even more importantly, we are running a full drug interaction check because that stuff is a powerful enzyme inducer. Okay, moving on to strep. With this bug, the treatment is all about sensitivity. It's dictated by the MIC to penicillin. If it's super sensitive, simple monotherapy with Pen-G or ceftriaxone for 4 weeks will do the job. But as soon as that MIC starts to creep up, we need to bring in the big guns. We add 2 weeks of gentamicin for Synergy to make sure we knock out that infection for good. I just want to pause on this for a second. 4 to 6 weeks. That is a long time to be on IV antibiotics. This prolonged course is exactly why our role in managing IV access, watching for side effects, and setting up outpatient therapy is so unbelievably vital for a good outcome. And last of the big three, we have Enterococcus. Let me tell you, this bug is tough. It's notoriously hard to kill. Unlike the others, you pretty much always need combination therapy right from the get-go to even have a chance at a cure. Synergy is the name of the game here.
So when we do use gentamicin for synergy, especially with enterococcus, our dosing goals are a bit different. We're aiming for lower peaks, just enough to get that synergistic effect. But the counseling is exactly the same, and it is non-negotiable. You have to warn every single patient about the risk of hearing loss and kidney damage. And remember, if you have a high-risk patient, that ampicillin plus ceftriaxone combo is a fantastic alternative that lets you avoid aminoglycosides altogether.
All right, we've talked a lot about treatment. Let's switch gears to prevention, because this is a massive area for pharmacist intervention, especially for those of you in the community. This has got to be one of the most common questions we get, right? A patient is heading to the dentist and they want to know if they need an antibiotic before their appointment. The answer is not as simple as it used to be. The guidelines have gotten way more specific. And here's your cheat sheet. Prophylaxis is now only for the absolute highest risk patients. We're talking people with prosthetic valves, a past history of IE, or some very specific heart conditions. It is not recommended for a lot of common things like pacemakers or stents. And knowing this difference is so crucial for preventing unnecessary antibiotic use. For those who do need it, amoxicillin is still the top choice. But the biggest, most important update for our practice is for our penicillin allergic patients. For years, we used clindamycin, right? Well, that's over. Clindamycin is no longer recommended because the risk of causing C. diff is just too high. So instead, we're using great alternatives like cephalexin, azithromycin, or doxycycline. This is a huge practice change.
Okay, to wrap things up, let's do a quick hitter round of therapeutic pearls. Think of this as your clinical cheat sheet of the absolute must-know points we talked about today. Here we go. Pearl number 1. That 4 to 6 week treatment clock, it doesn't start on day 1 of therapy. It starts on the day of the first negative blood culture. 2. Always, always, always check renal function before and during therapy with Vanco or gentamicin. 3. Oral step-down therapy is becoming a thing, but for now, that's a decision for an ID specialist. 4. Smart prophylaxis. If a patient's already taking an antibiotic, pick something from a different class for their procedure. And 5, this one is fascinating and so important. If the bug is Streptococcus gallilyticus, that patient needs a colonoscopy. It is a huge red flag for colon cancer.
And that's our deep dive into infective endocarditis. You know, from dosing vancomycin to counseling on a new prophylaxis guideline, the pharmacist is such a vital part of the team. And the field is always changing. As we see more interest in things like oral step-down therapies and face the constant threat of resistance, our role is only going to get more important. So the question we should all be asking is, how can we keep evolving our practice to meet those challenges head on? Thanks so much for joining me.